You're watching CTOM TV. Knowledge is power.
Basically, treatment is defined by how much of this Philadelphia chromosome you have in your blood.
Oh,
So if you have a certain amount of it, and then you go on a drug for treatment, chemotherapy plus a targeted therapy, then they look at the response. It's called the major molecular response criteria,
okay.
MMR. And basically what it does is they look at you at 12 months and they want to ensure that you have less than or equal to 0.1% of this Philadelphia chromosome and the ratio of it. And they compare that to the amount of ABL genes, which are not attached to the
Philadelphia.
BCR. Yeah, so they're not in, it's just a standard. And they typically look at around 3,000 different ABL transcripts and create that ratio.
Okay. And you said about a year in, so you've had treatment for a year and they're testing you now?
Exactly.
Okay.
Yes. And so the types of drugs that they use, the first drug that was ever, we consider this the first targeted therapy, the first start of precision.
Ever.
Yeah, the first start of precision medicine. This the first really beneficial one, and it was called Gleevec, also known as imatinib. And when that drug came out, I believe it was FDA approved late 2001, 2002, I think it's 2002. The survival went from around 30-31% right up to about 60% in these patients. So it was a really significant difference, and it was a long-term survival.
Wow.
So it
That's
changed
exciting.
the course of the disease significantly.
Wow, and that's almost 20 years ago.
Yeah, and since all patients have this 95% of patients, not all, 95% have this Philadelphia chromosome. That means a high, if you have CML, there's a high chance that it's not going to kill you.
That's
and in
right.
fact, nowadays, patients with CML have about the same survival rates as the average population. So it's considered definitely a treatable cancer.
You mean the average population without cancer?
Yeah.
Wow.
Yeah, it's close to it. So, however, not everyone responds to treatment, as you know, and many things can happen during the course of this disease. So right now we have two different classes of drugs, well, three different classes of drugs. They call tyrosine kinase inhibitors. The first one was Gleevec, imatinib, and that was from 2002. The two different classes of drugs are called type 1 and type 2.
Okay.
And then we also have something called mixed drug, which is relatively new. So type 2 drugs are the most common. Gleevec is a type 2. And what it does is it has what we call stringent binding. And stringent binding requirements. So what means is it's very selective for that Philadelphia chromosome alteration, and it binds onto it, very specifically. So it has this stringent binding. You have to have that mutation, and it binds onto it and breaks down the actual transcript, the Philadelphia chromosome.
But that is why it works so well.
Exactly, and it's very selective. But the problem with that is then if you have a mutation that is not part of the standard fare, the drug stops working. So you can develop mutations in this Philadelphia chromosome, and then of course the drug stops working. And so that actually happens quite a bit. So the type 1 drugs are what we call promiscuous. In other words, they're not as specific, but they're less prone to resistance based on mutations. And then you have the mixed that have the features of the type 1 and the type 2.
Okay. So the stringent binding, but a little farther afield.
Yes, exactly. Yeah, so not as general.
And what are the kinds of results that I can imagine, type 2 is quite beneficial, as you say, as long as things don't mutate.
Right, exactly. And they typically do.
Okay.
Yeah.
Right. So good place to start, but often you'll need more.
Right. So I have this little diagram that I made. So this is the ABL gene, as you can see.
Okay.
And so This is just a list of some of the mutations to imatinib that can occur and where they occur in the gene. So as you can see, there's quite a few of them.
We'll post that to the
we'll
chat
post
for
that,
you,
yes.
by the way. So, because
So there's you know, a variety of mutations that can occur over time and provide resistance to imatinib.
okay, that's what you were just showing us.
Yes, that's what I was
okay.
just
So it
showing
kind
you.
of goes. So we could kind of get the sense it kind of goes all over the place. We'll post that for you to have a sense.
The most common ones occur in what we call the KD mutations, and they enable. So there's some specific mutations that are targets of a lot of the research that seem to occur. And typically, what the scientists do is they'll say, well, we're seeing a lot of this mutation, so let's design a drug that overrides that.
Right. Which again, if they're, if 95% of people with that particular CML type of cancer
Respond to the drug.
Yeah, so you can understand why that was one of the first targeted therapies ever, because it was such a high number of people with that diagnosis who had that mutation. Right. Yeah. So there are
so 95% of the people have that mutation. Doesn't mean 95% will respond to the drug.
No. If I said that, that's not what I meant to say, but yes, thanks for the clarification. So, but I'm just kind of now wrapping my head around, okay, that makes sense why that was the very first targeted therapy, or, what, because
it's a perfect
there aren't very many that have, even breast cancer where, BRCA1 is very prevalent, but it's not anywhere near that prevalent.
And it's a different mutation, in every person. Very few people have the same mutations.
Same type of BRCA mutation, you mean? Exactly. Yes, that's we'll come back to that another topic.
That's where it gets complicated.
Yeah. Okay.
So imatinib, this first drug from 2002, as I mentioned, it dramatically doubles the survival rates of people with this disease. It also targets a bunch of different signaling pathways. One of them is referred to as KIT, and another is PDGFR, another one is DDR1, and because of that, it's been used in it's being investigated in other diseases that have these mutations. For example, KIT is common in something called gastrointestinal stromal tumors, and so they typically have high KIT expression. And so this drug has shown to be effective somewhat in those patients too.
And that's something that you're seeing a lot of too, isn't it?
Yeah, off-label.
Yeah, definitely. That's what that means, by the way, off-label. If a drug was designed for something else, but they're discovering it works for something else.
And even in AML, I think, even acute myeloid leukemia, I think, even 1% of patients have a Philadelphia chromosome aberration. So in those patients, you can definitely use this drug. So then often patients develop resistance, and they weren't too sure, but now they understand why they develop resistance. I showed you that mutational page and all the different possible mutations. So along came nilotinib in 2007, I believe, and that is the next generation drug, and it was designed to treat patients that were imatinib resistant.
Okay.
So basically the way Gleevec or imatinib works is it kind of folds the chromosome into a position where it can't turn on.
Okay.
Locks it into an off position.
Oh, okay.
And so nilotinib was developed for imatinib resistance. It has 10 to 30% or 10 to 30-fold more activity than imatinib, so it's a much stronger drug. Works in a similar pathway. It can also be used for GIST, gastrointestinal stromal tumors, because it targets a lot of the same.
The high KIT.
Yeah, the high KIT, and targets some other pathways too. But it has a 92% response rate in imatinib-resistant patients. So that's a very, very effective drug.
Wow, yeah, 92%.
Yeah. And then we also have a new one called ponatinib. And once again, that's a new advance in targeting this Philadelphia chromosome. So it came out in 2012, 2013, but I think there was some problems with blood clots or something, or some side effects. So they had to play with it and play with the protocol a bit and come up with some, slightly different protocols for it. But it was approved, 2013. And so it's interesting because what it does is it targets the not only does it target the Philadelphia chromosome itself, the original Philadelphia chromosome, but it also targets the mutant forms of that.
Ooh.
So,
So
when you have resistance, you have mutant forms of the BCR-ABL.
Right.
And this targets both the normal and the mutant forms. So it's a much better drug.
Yeah.
And so it's going to work when patients are resistant to nilotinib and imatinib.
So it works from the start, and then as things start to morph, it continues to work.
Yeah, exactly.
Wow. That's
It's
exciting.
typically used as a later line, though, when people become resistant.
Oh, I see.
It's because it's such a new drug.
Right. So it's more costly, or they keep...
Yeah, a bit of that. And I think just the process is, let's keep you on a drug that we're comfortable with.
Oh.
And then, once that stops working, we'll bring in, the new recruits.
Ponatinib.
So all three of those drugs are type 2, so they have this stringent binding. More specifically, ponatinib targets what's called a gatekeeper mutation.
Okay.
And this is something that happens. This is one of the mutations I just showed you in that diagram, this one. It's a gatekeeper mutation that occurs in what's called a KD domain.
Okay.
And so I believe there's just in the KD domain, there's about 12 different mutations that cause resistance.
Wow.
The main one is the T315I. And so this drug was designed to target that mutation specifically because it's a very common one.
Okay. But it also seems to affect others beneficially as well.
Yes, yes. And then you have the type 2 drugs, the promiscuous ones that are more general.
You mean the type 1?
Sorry, type 1, yes. Sorry. Type 2.
All right. I'm making notes here. That's how you know I'm making notes.
Yes, so the type 1. And there's a drug called dasatinib. And that also was designed for imatinib resistance. And then there's another one called bosutinib. Bosutinib, I believe it is. And that came out in 2012. And so that is kind of mixed. So it functions as a type 1 and also a type 2.
Huh.
And so, the type 1 typically lock the Philadelphia chromosome in that closed position, as we mentioned earlier on that. So this one inhibits. So this is mixed. So it uses type 2 and type 1, but it inhibits. I think it was about 16 out of the 18 imatinib resistant subtypes. So that's quite a development.
Wow.
Yeah.
So people are still started on the Gleevec as a matter of course, because it covers things so well.
And it's a well tolerated drug, and we know it really well.
But increasingly, you're saying there are these new options for when should you start to develop some resistance to that treatment, that 98%, 92% response rate.
Just for nilotinib, Now, unfortunately, bosutinib doesn't seem to work on this gatekeeper mutation, the T315I.
Okay.
So it doesn't seem to work on that one, but that's okay because ponatinib does.
And you could be tested to see if you have that mutation before you picked one or the other. You should be. Right.
Whether it happens or not, it depends on where you're getting treated, I guess.
Okay.
So you should be tested for that.
Right.
I think the process has been to just try the drug out and see if you respond or not.
Well, and the reason for that largely is because, really, genetic testing has come along in leaps and bounds in the last few years. It wasn't as accessible, by far 10 years ago as it is now.
Right.
So I can understand why doctors, if there's a reason to assume it could be beneficial, might just give it a try. But now there's a way to actually know whether it's going to work for you or not. So you don't have to kind of do the trial and error anymore if you've had good genetic testing. Yeah.
So resistance does occur eventually on imatinib. I believe, somewhere 50 up to 90%, depending on how long you live.
Okay.
But obviously there's some treatment options.
Yeah.
So as I mentioned, the main area of research has been on these KD mutations, KD domain mutations of ABL1. But now what we're starting to see too is mutations in other signaling pathways. So on top of just this Philadelphia chromosome, we're also seeing mutations in the STAT STAT3 signaling pathway,
Mm.
the PI3K AKT pathway, which are common in breast cancers and many other cancers, the RAF, MEK, and ERK pathway, and then also in a mutation we see quite a bit of actually when we sequence. It's called the EZH2. And that's what we call a class of proteins called histone methyltransferases. So there are methylases, and these kind of are getting into what we call the epigenetic approach. So they don't target specific mutations, they target the methyl and acetyl groups that bind to DNA and are involved in the regulation of DNA, of turning genes on and off.
What types of drugs are those called?
Methyltransferases.
Methyltransferases. So is that the evolution then?
They've been around for a while.
They've
been around for a while, and they're general. So they act very much like chemotherapy drugs. In other words, they don't just target a certain region of the genome that has methyl changes in the methylation. Methylation is a process that is involved in regulation of how long a gene gets turned, or if a gene gets turned on. It causes the DNA to be, when you add a methyl group to the DNA in the promoter region, what happens is it prevents it from being turned on.
Okay, so if I want to stop this pathway from functioning, I use one of these, or is it not?
Gene turning on or off. The problem is with these drugs is they do it across the whole genome. So you're turning on drugs and turning off drugs randomly, and that's why they haven't been used a lot.
Got it.
But in cases, where you have a methyltransferase issue, like this EZH2, these drugs could potentially be more beneficial in those patients.
I see. So that's still being explored?
Yeah. So what this does is this opens up treatment options. These other pathways open up treatment options above and beyond just targeting the Philadelphia chromosome. So, rather than just, we started out with just targeting the Philadelphia chromosome and all its mutations, and we have some, good drug players there. We're also looking at new areas now, other signaling pathways, so we could use different drugs that we use in breast cancer, or prostate cancer, or lung cancer, or melanoma, to target these other signaling pathways in combination with these, with imatinib and nilotinib and these other drugs.
And at the risk of asking a really obvious question, what is the benefit of being able to do that over just the Gleevec? Or
well, because a lot of the resistance is probably coming from those pathways.
Okay, so it gets ahead of any of the treatment resistance.
So patients that have tried all 5 drugs and they're still not responding,
I see.
we could start looking at these other pathways.
Okay, and this is a way potentially to get your body to respond to the drug.
Or just other drugs in combination. So it's a combination therapy. But what this does is it gets us back to the original issue. Is typically, you would have your Philadelphia chromosome sequencing. In some cases, you'd have the new mutations sequenced if you stop responding, mostly in clinical trials. But now, this opens up the whole question of, we should be, shouldn't we be sequencing these patients too? Shouldn't we be doing full genome analysis, full genome sequencing of these patients to see if they have other altered pathways above and beyond the Philadelphia chromosome?
That will affect how well and how long the treatment works.
Exactly.
Or
if there's a treatment, maybe they could take a mTOR inhibitor, for example, or an EGFR inhibitor in combination. So it's going to take us back to the drawing board. So we started with this one feature, and now we're realizing that there's many other features that we need to address.
Seems to be the common theme.
It is, yes, definitely.
Yeah, that the more we learn, it's that Dunning-Kruger effect. The more we learn, the more we realize we don't know.
Yeah.
But the good news is, as we're realizing what we don't know, there are increasing number of these drugs that are having far better benefits to people. And again, that genetic testing is allowing your doctor to start you out on a much more effective treatment regime and perhaps get ahead some of this resistance. That's exciting.
Yeah, so we're hitting it from many different angles.
Yeah, and again, there's just going to be more and more of that.
Totally.
Because we're just getting started. As you were saying earlier this hour, there's 11 pathways that we know of that are potentially involved in cancer progression, and we've really only started to look immune system, and we've really only started to look at 2 and a bit.
3. Yeah.
Well, that first one you said, or that third one you said is in
kind of
we don't really have anything for that.
We do have a drug.
Oh yeah, there is one,
and it's being used. We're just not sure where it's being used or the best.
I'm still going with 2 and a bit then, because but anyway, that means there's still so much more to be discovered.
Definitely. Yes.
Yeah.
Thank you for watching CTOM TV. Subscribe below and stay informed.